Hello everyone, good afternoon. Welcome everyone here for the ADC webinar 190, Implantology Series 1.0 and webinar number 2. First webinar, Basics in Implantology, is presented already 2 weeks back by respected mentor Dr. Ashvini Vadane. Let me introduce today's speaker. Dr. Ashvini Vadane Apte is a renowned oral and maxillofacial consultant surgeon. She has her own practice by name Arunika Oral Surgery Dental Clinic in Pune. She is a faculty at Dental College and she's a visiting and consultant oral and maxillofacial surgeon for areas in Pune, Mumbai, Navi Mumbai, Thane, and around areas. She has presented multiple webinars for oral surgery for ADC as well as other academies online and courses also she has conducted. And she is a mentor for oral and maxillofacial surgery topic and implantology. So let's welcome her today. And this is a second topic, that is osseointegration and dental implants. So let's learn from her. Welcome, ma'am. Over to you.
Yes. Uh, Thank you so much, Dr. Sudhir sir, for such a wonderful introduction. And thank you so much, Sir's Dental Academy, for giving me opportunity again. Is my slides are visible?
Yes, first slide is there. The welcome slide
Okay.
is there. Yeah.
Yes. So, last time I had covered the introduction about the dental implants.
Yeah.
Today, I will cover the osseointegration process in the dental implants.
Yes.
Okay, so osseointegration, it is the theoretical topic, but it is very much important because it comes under the basics related to the dental implants. So today we will see the osseointegration in dental implants. The contents of today's topics will be introduction, theories of bone to implant interface, mechanism of osseointegration. There are various mechanisms. We will go through that. Then factors responsible for successful osseointegration. Then methods of evaluation of osseointegration, and then the conclusion. So this is all related to the osseointegration process. The word osseointegration itself indicates osseon means bone. So how the implant integrates with the bone. That is all about the osseointegration. Introduction. The successful replacement of lost natural teeth by tissue integrated tooth root analogs. As seen in this picture. So this is the implant. So that is the tooth root analog. It is the major advancement over the last 25 years. Today, the continued high rate of success achieved with these osseointegrated dental implants allow a greater number of patients to enjoy the benefits of a fixed rather than the removable restoration. So this is the, we can say the good advancement in dentistry over the last 25 years, dental implants. So how this concept evolution of osseointegration concept. We will quickly go through the history. In the past, the direct contact between the bone and metallic implants, it was regarded as impossible to achieve. And the supporters of this theory were some scientists, Linkow, James, and Weiss. According to these scientists, it was impossible. The term osseointegration was coined by Dr. Per-Ingvar Brenmark, professor at the Institute of Applied Biotechnology, University of Gothenburg, Sweden, in the year 1985 to describe the direct In January 1986, the Brainmark Clinic for Osseointegration implant treatment, it was established within the School of Dentistry at Göteborg University. Since then, the science of osseointegration evolved in both laboratory as well as clinical environments, and also as a result of extensive multidisciplinary cooperation. Brainmark has also been credited for finding out the most biocompatible implant material as titanium. So this was the history. Now we will go through the definition. Osseointegration, it is defined as a histological, structural, and functional. All terms are important. It should be at the histological level, structural level, and functional level. So it is the histological, structural, and functional direct contact between the bone and bone marrow with titanium-based implants without fibrous tissue. Okay, in this there are no fibrous tissue. The osteotomy site, it should heal with intramembranous ossification without cartilage tissue formation. Bone in contact with the implant surface undergoes morphological remodeling as adaptation to stress and mechanical loading. This is the osseointegration. Then there are various definitions proposed by various scientists. You will get all these definitions in the textbooks. Now we will see the theories of bone to implant interface. So there are two basic theories regarding the bone to implant interface. The first one is the fibro-osseous integration, and the second one is the osseointegration. Okay, so first of all, in introduction slide, we had seen that Linko, James, and Weiss, he had proposed the fibro-osseous integration. So the first one is that theory. And the second one is the osseointegration, which was proposed by the Brainmark. So what is fibro-osseous integration? Fibro-osseous integration, it refers to a presence of connective tissue between the implant and bone. In this theory, collagen fibers, they function similarly to Sharp's fibers, which are found in the natural dentition. All of us knows that in natural dentition, we will see the periodontal ligament, Sharp's fiber. Everyone knows that. So, according to the fibro-osseous integration, it this concept, it denotes that there is the presence of connective tissue between the implant and bone, and the collagen fibers, they function similarly to the Sharp's fiber, which are found in the natural teeth. The fibers affect the bone remodeling where the tension is created under the optimal loading conditions. So this is the fibro-osseous integration. In 1986, the American Academy of Implants Dentistry, it defined the fibrous integration as tissue to implant contact with healthy, dense, collagenous tissue between the implant and bone. Then Weiss, he stated the presence of the collagen fibers at the interface between the implant and bone is a peri-implant membrane with osteogenic effect. He believed that the collagen fibers, they invest the implant, which originate at the trabeculae of the cancellous bone on one side, weaving around the implant and reinserting into the trabeculae on the other side. So these are the various concepts proposed by various scientists. But this theory, fibro-osseous theory, was failed. So this is the reason the conventional implant systems have always had a fibrous capsule or fibrous tissue interface along the surface of the implant, which has been referred to as a pseudo-peri-implant membrane. It was felt that this membrane gave a cushion effect and acted as a similar periodontal membrane in the natural dentition. However, there was no real evidence to suggest that these fibers functioned in the mode of the periodontal ligament. Hence, when in function, the forces are not transmitted through the fibers as seen in the natural dentition. Therefore, remodeling was not expected to occur in the fibrous integration. Moreover, the forces applied, it resulted in the widening of the fibrous encapsulation and proceeded by the inflammation and gradual bone resorption. And all this led to the failure of this theory. Then came the theory of osseointegration. So Meffert et al. In 1987 redefined and subdivided the term osseointegration into adaptive osseointegration and biointegration. Adaptive osseointegration, it has osseous tissue approximating the surface of the implant without apparent soft tissue interface at the light microscopic level. Whereas biointegration, it is the direct biochemical bone surface attachment confirmed at the electron microscope level. This is the difference. Am I audible?
Yes, it was
Yes. Yes.
disconnected, but again,
Yeah.
it's connected.
That's
Yeah.
why, huh?
Now
So,
correct.
yes, unlike fibro-osseous integration, osseointegration, it was able to distribute the vertical and slightly inclined loads more equally into the surrounding bone. To obtain a successful osseointegration, Brainmark and co-workers proposed numerous factors. According to the proponents, the oxide layer should not be contaminated, or else inflammatory reaction will follow, which further will result in the complications like granulation tissue formation, etc. The temperature during the drilling, it should be controlled by copious irrigation. If not, it can inhibit the alkaline calcium synthesis, thereby preventing the osseointegration. So there should be copious irrigation. The first month after the fixture insertion is the critical time period for initial healing period. When the loads are applied to the fixture during this period, the primary fixation is destroyed. So these were the two theories, fibro-osseous integration and osseointegration. So fibro-osseous integration, it failed uh, over the period of the year, and most accepted is the osseointegration. That's why we are studying this topic, osseointegration in the dental implants. Now we will see the mechanism. So mechanism of integration, it was proposed by Osborne and Newsley in 1980 and by Davis in 1998. So first of all, we will see the mechanism of integration which was proposed by Osborne and Newsley in 1980. The terms distance and contact osteogenesis were first described by Osborne and Newsley in 1980, and it refers to the relationship between the forming bone and the surface of implanted material. Their terms described essentially two distinctly different phenomena by which bone can become juxtaposed to an implant surface. So they proposed two osteogenesis, distance osteogenesis and contact osteogenesis. In distance osteogenesis, new bone is formed on the surface of the bone in the peri-implant site. Similar to the normal appositional bone growth, the existent bone surface, it provides a population of osteogenic cells, and which will in this way there will be continuation of osteogenesis which will encroach on the implant. Thus, an essential observation here is that new bone is not forming on the implant itself, but rather that the implant becomes surrounded by the bone. Okay, that's why it's the distance osteogenesis, because there is no contact. In these circumstances, the implant surface will always be partially obscured from bone by intervening cells and generally the connective tissue extracellular matrix, which makes bone bonding impossible to achieve. That was the distance osteogenesis. Now the contact osteogenesis. In contact osteogenesis, new bone forms first on the implant surface. Since no bone was present on the surface of the implant, upon implantation, the implant surface, it must become colonized by a population of osteogenic cells before initiation of bone matrix formation. This occurs at the remodeling sites where an old bone surface is populated with osteogenic cells before new bone can be laid down. These osteogenic cells, they migrate to the implant surface. So, as in this second type, there is the contact between the bone cells and the implant. It is the contact osteogenesis. While both distance and contact osteogenesis, this will result in the juxtaposition of bone to the implant surface. The biologic significance of these different healing reactions is of considerable importance in both attempting to unravel the role of implant design in endoosseous integration and in elucidating the differences in structure and composition of bone to implant interface. So these were the this was the mechanism, distance and contact osteogenesis, which was proposed in the 1980 by the Osborne and Newsley. Then after that, in 1998, Davis, he has proposed another mechanism of integration. He divided the contact osteogenesis into two distinct early phases of osteogenic cell migration and de novo bone formation, and a third tissue response that consists of bone remodeling at the discrete sites. So in this, first of all, we will see the osteoconduction. The term osteoconduction, it refers to the migration of differentiating osteogenic cells to the proposed site. These cells, these are derived at bone remodeling sites from undifferentiated perivascular connective tissue cells. A more complex environment, it characterizes the peri-implant healing site, since this will be occupied transiently by the blood. So this is the osteoconduction. In this case, as in fracture healing, migration of the connective tissue cells, it will occur through the fibrin that forms during the clot resolution. Fibrin, what it is? It is the reaction product of thrombin and fibrinogen, which is released into the healing site and can be expected that it can adhere to almost all the surfaces. It is via this that the osteogenic cells get migrated. The migration of cells through a temporary matrix such as fibrin, it will cause retraction of the fibrin scaffold. Thus, the ability of an implant surface to retain fibrin attachment during this wound contraction phase of healing, it is critical in determining the migrating cells will reach the former or not. This phenomenon of osteoconduction, it relies on the migration of differentiating osteogenic cells to the implant surface. The implant design, it can have a profound influence on osteoconduction by maintaining the anchorage of the temporary scaffold through which these cells will reach the implant surface. And this can be predicted that the roughened surfaces, it would promote the osteoconduction by both increasing the available surface area for the fibrin attachment and providing the surface features with which fibrin could become entangled. So this was the osteoconduction. Now we will see the de novo bone formation. An essential prerequisite of de novo bone formation, it is the recruitment of potentially osteogenic cells to the site of future matrix formation. Differentiating osteogenic cells which reach the implant surface, they initially secrete a collagen-free organic matrix which provides the nucleation sites for calcium phosphate mineralization. The two non-collagenous bone proteins like osteopontin and sialoprotein, These two proteins had been identified in this initial organic phase, but there was no collagen. The calcium phosphate crystal growth, it follows the nucleation, and concomitant with the crystal growth at the developing interface, there will be the initiation of the collagen fiber assembly. Okay, so finally the calcification of the collagen compartment, it will occur both in association with the individual collagen fibers or in the interfiber compartment. Thus, in this process, there is the de novo bone formation. The collagen compartment of bone, it will be separated from the underlying substratum by a collagen-free calcified tissue layer containing the non-collagenous bone proteins. So, this is the mechanism. Then the bone bonding in the de novo bone formation. How does the bone bonding occurs? Although all this is a theoretical part, it is very much important because our today's topic is the osseointegration. That's why everyone should know how this osseointegration takes place. That's why I'm covering this in detail. So bonding of de novo bone, it will occur by the fusion or micromechanical interlocking of the biologic cement line matrix with the surface of the reactive layer of the substratum. In other areas where connective tissue collagen, it is in contact with the implant, it will become encrusted in the surface reaction layer of so-called bioactive materials to produce the ultrastructural appearance of the collagen interdigitation. Then comes the bone remodeling. During the long-term phase of the peri-implant healing, it is the only through those remodeling osteons that actually impinge on the implant surface that de novo bone formation will occur at these specific sites on the transcortical implant. The remainder of the transcortical portion of the implant, it will be occupied by old dead bone or connective tissue space which was created by the peri-implant necrosis and lysis of bone tissue. And calcium phosphate, it accelerates the early peri-implant bone healing by potentiating the osteoconduction through the structural protein adsorption and retention during the early healing. In this view, it is possible to envision that biologic design strategies for dental implants have surfaces that are replaced by bone during the normal tissue remodeling. Moreover, it is also seen that the calcium phosphate coating, it can be site-specifically resorbed by the osteoclasts. Okay, so in this way, this was everything about the theories of osseointegration and how the osseointegration takes place actually, so that the scientists or the companies which produce the implants, they come to know how to prepare the implant design by these mechanisms. That's why it was important to go in the detail. As well as if some UG students are attending this, it comes as a theory questions also. Now we will go through these charts. So mechanism of osseointegration, the first phase is the inflammatory phase, which occurs in the day 1 to 10 after placing the implant. Okay, so in this, there will be adsorption of plasma proteins, then platelet aggregation and activation, clotting cascade will get activated, cytokine release will occur, then specific cellular inflammatory response is seen, and then macrophage mediated inflammation. So this comes under the inflammatory phase and the timing is day 1 to day 10. Then second is the proliferative phase, which occurs from day 3 to day 42. So in this, there is the neovascularization. That is the formation of new blood vessels. Then differentiation and proliferation and activation of cells. And then production of immature connective tissue matrix. It occurs from day 3 to 42. That is almost we can say till the 1.5 month. And after the day 28, maturation phase, it takes place. This is the remodeling of the immature bone matrix with coupled resorption and deposition of bone. And there is the bone remodeling in response to implant loading. This is the maturation phase. So we can quickly revise the mechanism of osseointegration in these three phases. Then comes the stages of osseointegration. Okay, we saw the introduction, history, definition, theories, mechanism. Now we will see the stages. Stages of osseointegration. So according to Mish, there are two stages in the osseointegration, each stage being again divided into two substages. So two stages are the surface modeling and remodeling. Surface modeling is divided as the first one is the woven callus, which is seen 0 to 6 weeks. Then lamellar compaction 6 to 18 weeks. Then comes the remodeling. In that the interface remodeling 6 to 18 weeks. And then the stage 4 compact maturation, that is seen in the 18 to 54 weeks. These are the stages. Now the factors which are responsible for the successful osseointegration. The first one is the implant biocompatibility. Means the implant which you are going to place in the oral cavity, it should be biocompatible. The oral tissue should accept it. Then design characteristics, the surface characteristics, state of the host bed. So these three things, significance of these three things, we have understood in the mechanism part. Design, surface and state of the host bed. Then comes the surgical technique and loading conditions. These are the factors. So first, we will go through this. So first one is the implant biocompatibility. Response of bone to different